Welcome. So you've got a patient in front of you who is acutely dizzy. The big question is this just a harmless inner ear issue, or is it something far more serious, like a stroke in progress? This series from Australian Dizziness Clinics is designed to give you the essential bedside tools you need to make that critical distinction and to make it with confidence. In this explainer, we're zeroing in on the HINTS Plus exam. Now, this is a powerful bedside examination that, and this is the key part, when you do it correctly, is actually more sensitive than an early MRI for spotting a stroke in patients with acute continuous vertigo. Let's break down exactly how that works. All right, let's start by challenging a really common assumption. We're all trained to see MRI as the gold standard, right? It's our ultimate diagnostic safety net. The thing is, for a dizzy patient, particularly when you're worried about a posterior circulation stroke, there's a critical early blind spot, and it's one that can seriously lead us astray. And here is the number that should really make you sit up and pay attention: 20%. In the first 24 to 48 hours, a standard MRI with diffusion-weighted imaging can miss 1 in 5 small brainstem strokes. Now, this isn't a failure of the machine, it's just a physiological limitation. The huge takeaway here: a normal early scan does not mean it's safe to send that patient home. So if we know an early scan has this pretty significant blind spot, where do we turn? Well, the solution isn't necessarily bigger, more expensive technology. It's actually about going back to the bedside, but with a smarter, much more structured clinical exam. And this is it, the HINTS Plus exam. It's a structured series of 4 simple bedside tests that focus on eye movements and hearing. Now, get this. When you perform it correctly on the right patient, its sensitivity for stroke gets up to around 99%. That's a clinical exam outperforming our go-to imaging in that absolutely crucial early window. Okay, this is where you have to do a bit of a mental flip. We're so used to normal findings being reassuring, right? But with the HINTS exam, as this quote highlights, when a patient is so dizzy they can barely stand, the absence of clear peripheral findings is actually a massive red flag. A normal test can be the most dangerous result you can get. Let's dig into why that is. So let's get practical. How do you actually do this exam? We're going to walk through each of the 4 parts, and for each one, we're asking a single question. Is this a reassuring peripheral sign, or is it a red flag central one? First up is the head impulse test, or HIT. You have the patient fix their gaze on your nose, and then you give their head a small, rapid turn. Now, in a peripheral issue like vestibular neuritis, the inner ear just can't keep up, so their eyes will drag with the head, and then you'll see a little snap back to the target. That's called a corrective saccade. This is an abnormal test, and paradoxically, it's reassuring. But if that patient is super dizzy and their eyes stay perfectly locked on your nose, that's a normal test, and that is a huge red flag for essential cause. Next, we're going to look closely at the patient's nystagmus, that involuntary flickering of the eyes. A peripheral problem typically is going to cause a unidirectional horizontal nystagmus. That means the eyes are always beating in the same direction. It doesn't matter where they're looking. So what's the red flag? Any nystagmus that changes direction when they look left versus right, or any nystagmus that is purely vertical or rotational, that points straight to a central problem. The third piece is the test of skew. As you alternately cover one eye and then the other, you want to watch really closely for any vertical movement. If you uncover an eye and you see it shift up or down to get back in line with the other one, that's a skew deviation. And any skew at all is a highly specific sign for a brainstem problem. So that covers the HINTS. But we've got to talk about the plus. It's a really simple addition, but it's absolutely critical. It was added specifically to catch a certain type of stroke that can perfectly mimic a simple inner ear problem. The plus is just a simple bedside hearing screen. You can just rub your fingers together by their ear. The reason this is so important is that if your patient has acute vertigo and new one-sided hearing loss, that is a massive red flag. This combination is the classic sign of an AICA territory stroke. Because that artery supplies both the inner ear and parts of the cerebellum, the stroke presents with both hearing loss and vertigo, looking for all the world like an inner ear infection like labyrinthitis. This has to be treated as a stroke until you can prove it's not. Okay, I know that's a lot to keep straight, especially at 3 a.m. when you've got a really distressed patient in front of you. But thankfully, there's a fantastic mnemonic that helps lock in this dangerous red flag central pattern. And that mnemonic is INFRCT. I is for impulse normal. N is for nystagmus, that's fast phase alternating, meaning it changes direction. And F is for refixation on cover test, which is our Skew. Now, the crucial part is you only need one of these to have a positive test that points to a central cause. And of course, the plus is always there to remind you to screen for that one-sided hearing loss. All right, this next part is incredibly important. Before we all run out and start using this powerful tool, we have to talk about its single biggest limitation. It's the one thing that directly impacts patient safety. The HINTS exam is an instrument, and just like any instrument, its accuracy depends entirely on the person using it. This slide really shows the operator dependence trap in stark numbers. In the hands of trained experts, the sensitivity is near perfect, 99%. But for clinicians who don't have specific, repeated training, that sensitivity can plummet all the way down to 83%. And that's not a criticism, it's just a reality. An 83% sensitivity means you could be missing almost 1 in 5 strokes, which brings us right back to that MRI blind spot we were trying to get away from in the first place. So the bottom line is this. Your confidence in what you're seeing is everything. If you do the HINTS exam and the findings are kind of muddy, or you're just not totally sure what you're seeing, that is not a negative test. An equivocal HINTS exam means you cannot use it to reassure the patient or yourself. If you're in doubt, the next step is always to escalate, get imaging or an expert opinion. Okay, let's distill all of this down. If you walk away from this explainer and you change 3 things about your practice, what should they be? First, trust your clinical skills. A well-performed HINTS Plus exam is more sensitive than an early MRI for stroke. Second, know the red flags. Burn that ionophic mnemonic into your brain so you can spot them quickly. And third, and this is the most critical one, know your own limits. If you are anything less than 100% confident in your findings, the test is equivocal. You need to escalate care. You do not reassure. So, now that we have this powerful examination tool, how do we actually fit it into a practical workflow? Well, join us for our final explainer, where we'll put it all together into a clinical algorithm for triage, imaging, and disposition. Thank you for joining us for this explainer. To explore more topics on dizziness, vertigo, and imbalance, and to access a whole range of clinician and patient resources, please visit our website at australiandizzinessclinics.com. And hey, don't forget to subscribe.